as the patients who receive these joint replacement operations live longer, we are tending to see more and more this type of X-ray appearance. This talk was put together by my partner, Dr. Shemich, and myself, and he has a special interest in the management of periprosthetic fractures of the femur. As you know, there's been a tremendous amount of work done on periprosthetic femoral fractures around total hip replacements. And that's partly because at one time, total hip arthroplasty was much more common than total knee arthroplasty, and therefore we've had more experience with these implants in people for longer periods of time. There was also a lot of work done on this because we weren't aware of the importance of long-term surveillance of patients undergoing joint replacement surgery. What's happening now, however, is that there's increasing periprosthetic fractures around total knee replacements as the number of knee arthroplasties now in North America at least are double the number of total hip arthroplasties. So we are seeing more fractures around total knee replacements, and our knowledge about how to manage these is somewhat incomplete. Certainly we don't have anything as well known as, or as recognized as the Vancouver classification around stemmed total hip replacements. Now, what they've identified in looking at proximal femoral fractures is that the B fracture, the fracture right around the implant, is the problem. And what they've also recognized is that the management of this fracture is largely dependent on the need for revision of the loose or failed stem. And that, of course, is not the case in most total knee replacement fractures. So the lessons that we've learned in managing proximal femoral fractures are not necessarily applicable to the more distal femoral fractures around the total knee replacement. So, periprosthetic fractures after total knee arthroplasty. These are the questions that I think we have to answer with regard to this particular problem. First of all, if you see a notch either during or immediately after surgery, does that require treatment? If a fracture does occur, what is the evidence supporting either a nail or a plate? What's the best for the small distal fracture fragment? Are locking plates better than conventional plates? Do allograft struts for mechanical support make a difference in the distal femur as they do in the proximal femur? Because of the poor quality of the distal bone, is cancellous bone grafting required? And finally, what are the specific contraindications to nailing and or plating in these fractures? Well, there's certain risk factors, significantly osteopenia, which we see in patients with rheumatoid arthritis, for example, many neurologic disorders, or patients on steroids. There's no question that when you cap the femur, when you put the femoral component on the distal femur, you create a very large stress riser between the bone and the implant. And I think patients with osteopenia are at significant risk for periprosthetic fractures with minimal stress across their knee. Now, we do know from mechanical testing that a 3 millimeter notch gives us a 30% decrease in strength of the bone, whereas a full thickness or full cortical notch decreases up to 42%. The important factors are the size, the location, the depth, and whether or not there's a sharp edge. So if you do get a notch, you should round the edge off and bone graft that to try and decrease the depth. However, Ritter, in a review of a large number of total knees, noted that while there were 30% of notches in his series, he had no fractures. There was no effect on the outcome for the patient. Gujarat, 200 patients at 9 years, 41% had notches documented on their post-operative x-ray, but there was no relation between the notch and the outcome. So the notch in and of itself is probably not as important as its location and the patient himself. Now, here's an example of a large notch. You can see that this is not just a little cortical divot. This is a very large piece of the cortex that's been removed, and so there's a large stress riser immediately above the implant, and the inevitable has occurred, and there's now a supracondylar fracture of the femur occurring within a few days of surgery. Now, if a fracture does occur, there's argument about nail versus plate. And when we first started to see these fractures coinciding with the introduction of retrograde femoral nailing, there was a lot of enthusiasm for retrograde femoral nailing for the management of these patients. In a systematic review comparing, looking at different papers reviewing different types of treatment, they had 29 case series with 415 cases, and they found that ream nails in the management of these patients had an 87% risk reduction for non-union and a 70% risk reduction for revision versus the use of conventional plates. So certainly a reamed nail was better than a conventional plate for the management of these fractures. However, looking at locked plates, there was a 57% risk reduction fracture for non-union and 43% reduction for revision versus conventional plates. So locking plates make a difference compared to conventional plates, but what's the argument between ream nailing and locked plating? Well, does the locked plate make a big difference? It does, and when you look at these series. In Journal of Arthroplasty in 2008, they had 29 locked plates versus 29 non-locked plates or ream nails. And you can see that the malunion rate for the locked plates was substantially lower than for the ream nails or the non-locked plates. And all 7 patients with a ream nail had a malunion or a non-union. When Wick looked at the difference between the LIS and the ream femoral nail, he found that the less invasive system was better with osteoporotic bone than the small distal fragment. So certainly locked plates have a role in the management of these fractures. Now, plates and short distal fragments, if you have 28 fractures proximal to the tip of the flange and 33 distal, and there was no difference in delayed union, non-union, construct failure, or infection. So locked plates seem to function just as well with larger and smaller distal fragments, and that's not the same or not true for locked nails. Now, malunion is a major problem, and it's best prevented with a locked plate. So here's a periprosthetic fracture that you can see is rather comminuted. It's occurred right at the flange, which is the usual location for this fracture. And here's the reduction and fixation with the locked plate. Here's a similar fracture fixed with a reamed locked nail, and you can see that there remains a very significant flexion deformity through the fracture site. The AP X-ray on your right looks good, but the lateral X-ray shows that there is a persistent flexion deformity around this nail, partly because of the large distal fragment and the capacious medullary canal. So what's the evidence in terms of prevention of malunion? The systematic review of the treatment is done here by Ristevsky and Shemich. They have 719 fractures in this review, and you can see that the malunion for conventional plating versus locked plating is almost 3 times higher. Conventional versus reamed intermedullary nailing, there wasn't much difference between the two. And reamed intermedullary nail versus locked plate, malunion was twice as common with the reamed intermedullary nail. So the locked plate is clearly superior. So why is malunion a problem with retrograde nailing? Well, we have a metaphyseal fracture with a very large canal in most of these patients. The start point for the nail is fixed by the box of the femoral implant, and so you can't get the nail to start exactly where you want it and it tends to displace the fracture, you have to reduce the fracture prior to reaming, and we often have rather poor distal fixation. So here's an example of a distal third femoral fracture extending down to involving the knee arthroplasty. And you can see that there's a problem with the nail because of the very large diameter of the femoral canal. So there's overriding of the fracture fragments and persistent valgus deformity. Now, using allograft struts, we've done a lot of research on this around the proximal fractures around total hip stems. And we looked here at the fibular strut, the locking plate, and a femoral strut with plus a conventional plate. And what we found was that a fibular strut or a cortical strut graft was stronger than a lock plate alone in every plane that we tested biomechanically. And the load to failure, the fibula and the strut were both stronger than the lock plate. So a lateral non-locking plate in a medial allograft is stiffer overall than a locking plate alone. And an intermedullary fibular allograft with a lateral non-locking plate has intermediate characteristics. When maximum stiffness is required, a lateral plate in a medial strut may be optimal. So here's an example of someone who's had a fracture fixed with a lateral plate alone, and you can see it's failed into varus. And the application of a medial plate has addressed that problem. But we can do this with a strut graft instead of a plate, which augments the bone and makes it stronger. So an intermedullary strut, fibular strut, and a lateral buttress plate is what we use now, if we can, for these patients. Failing that, we tend to use a plate and a cortical allograft strut on the medial side. So here's a patient with a fracture secondary to a notch. Here's the fracture reduced, the guide wire placed, the medullary canal is reamed. There you can see the fibular graft in the center of the femur, providing both bone and rigidity, and then the application of the plate. Cancellous bone grafting is not required. There's no evidence that it improves the union of these rather difficult fractures. So when do we not use a plate? Well, if there's a large zone of injury, poor soft tissues, patients with diabetes or other significant metabolic diseases don't do well with the open surgery required plate fixation. Here's an extremely comminuted fracture, temporarily fixed with external fixation. This is an open fracture, and then fixed definitively with the nail. So in conclusion, I think periprosthetic fractures after total knees are very challenging, and unfortunately they are becoming more common. Restoration of anatomy with early motion results in the best function. These patients tend to have rather poor knee function to start with, and the fracture makes it worse. You should fix what you can as rigidly as possible and avoid compromised exposure, malalignment, and prolonged immobilization. So in conclusion, lock plating is best. IM nails are problematic with the osteoporotic femur. Medial allograft strut or intermedullary strut improves the stability tremendously. Avoid plates if you have poor soft tissues, metabolic disease, or large zones of injury, and you do not need routine cancellous bone grafting. Thank you.
Thank you very much.